I think for the sake of time, with your permission, I carry on to the final formal presentation by Professor Wiebke Arlt. Professor Arlt is Director of the Medical Research Council, London Institute of Medical Sciences, as well as Professor of Transdisciplinary Medicine at Imperial College, talking about omics approaches in adrenal disease. Thank you.
Many thanks for having me here, and many thanks to you for still sticking around for the last talk. And I will not be talking about genomics, so I'm quite interested in that. And this is our new building, so if you want to visit the MRC LMS, come and do so. We are on the Imperial Hammersmith campus, and we are very interested in clinical translational links, and it was great to have this interdisciplinary data array. Okay, so I will be talking about steroid metabolomics here at the end, and obviously we heard a lot about genomics, transcriptomics, epigenomics, but obviously in the effector arm is then proteomics, metabolomics, and we are very much interested in steroids. So this is sort of like the steroid system. As you know, the adrenals and gonads are steroid factories, and this shows you like the major areas. Green are the mineralocorticoids and their precursors, orange cortisol, the glucocorticoids and their precursors, and in blue testosterone and dihydrotestosterone, the potent androgens and their precursor steroids. And as you know, like in the Bible, Eve is made from Adam's rib, so there's no other way to female hormones than to be generated from male hormones. And all these hormones you can measure in by mass spectrometry in a multisteroid profiling approach. And also to make it, you can do this in multiple biological matrices. And one thing we are very interested in is urine steroid metabolomics, because it's an elegant, non-invasive way to measure the entire steroid output of the human body under certain conditions. And that can be done with gas chromatography, mass spectrometry, and high throughput tandem mass spectrometry. And the pioneer of this is Cedric Shackleton. And he has developed this 60 years ago and then refined it. And as you see here, these are 88 healthy adults. In dark blue, you see the androgens they excrete over 24 hours, and in orange, the glucocorticoids. So these are certainly the largest amounts of steroids we excrete. And you can nicely see that the androgen precursors in baby blue, the mineralocorticoids in green, and the glucocorticoid precursors are excreted in much lower amounts. Yeah? And so we have developed steroid metabolomics as a combination of mass spectrometry-based multisteroid profiling with machine learning-based data analysis. And in my talk, I want to give you two examples of this, how we can apply this to personalized and precision medicine. So the first example are adrenal tumors, and our first project is on the differentiation of benign adrenocortical adenoma from malignant adrenocortical carcinoma, and this is really important. These are data from the last 20 years or 25 years, and you see the number of incidentally detected adrenal masses is going up steeply, and overall these are found in like 5% of cross-sectional imaging procedures of the chest and abdomen. So here in purple you see the overall numbers, and you see in red this is really tracked by those tumors that are found incidentally. Yeah, while the number of tumors are found upon cancer screening and follow-up are pretty much staying the same. And if you detect an adrenal nodule, then there are two important questions. One is there hormone excess, because obviously the adrenal is a hormone factory. And secondly, is there malignancy? And obviously to the patient, this is a much more important question, because if you say tumor to the patients and not nodule, then they hear cancer, yeah? Because obviously they do not necessarily have the concept that a tumor may be benign or malignant. And so like you say, why can't we do this with imaging? And imaging is very sensitive, but it's very, very unspecific or very unsatisfactory in its specificity. So adrenocortical carcinoma is a rare and very malignant disease with no satisfactory treatment at present. And in a series of patients referred to endocrine service for workup of the adrenal nodule, they are found on average between 2 and 11%. This is the first patient I treated with adrenocortical carcinoma as a medical student. So this photo is taken with consent. So you can see that this is a really devastating disease. And as imaging is not performing well, novel biomarkers to detect malignancy are really urgently needed. And we explored the opportunities for steroid metabolomics there. This came from a very simple hypothesis. We said adrenocortical carcinoma cells are immature, differentiated, and adrenocortical adenomas are differentiated. So therefore, it would make sense to assume that in the adenoma cells, you will find in the urine steroid metabolome more of the end products of steroidogenesis, as differentiated cells will express all components of the steroid apparatus. While my hypothesis at the start of this was that in carcinomas, we would expect an accumulation of steroid precursors. At the time, basically, most of the carcinomas were classified as endocrine inactive. Yeah, when we started this work, 70 to 80% of adrenocortical carcinomas were described as endocrine inactive, but that was obviously due to the fact that only end products of steroidogenesis were measured in the normal assays. So to examine this, we took a cohort, a retrospective cohort of 150 patients in collaboration with the European Network for the Study of Adrenal Tumors and SAT, and did GCMS mass spectrometry to look at their steroid output. And then in collaboration with my colleague Mike Kubil, we undertook machine learning analysis, or specifically generalized matrix learning vector quantization. And this actually showed us that our hypothesis was right, and that there was actually a steroid fingerprint that with high sensitivity but also specificity differentiated benign from malignant adrenocortical tumors. And obviously this is a proof of principle study, so it is important then to undertake prospective validation, but obviously 90% specificity was unheard of as compared to the imaging procedures. So I show you briefly how this looks. You see here two nasty adrenal tumors. They are large and encircled. And so this is like how it works in practice. All the blue dots are steroid metabolomes from benign adenoma patients in their urine. All steroids excreted, projected into one point. And all the red dots are the entire steroid metabolomes from carcinoma patients. You see, this is our patient here on the 90th centile, so clearly highly suspicious for a carcinoma. Similarly nasty looking mass, but you see here, this is really completely somewhere else and certainly far away from the carcinomas. So no surprise, the patient on the left was operated, it was a highly malignant carcinoma. But on the right side, we actually decided for histology, for biopsy, and that was a good call because this was a primary adrenal non-Hodgkin lymphoma, and the patient underwent high-dose chemotherapy without delay. If the patient would have undergone a nephrectomy, adrenalectomy, and major surgery, this would have delayed the surgery by many months. Similarly, we can undertake monitoring of patients with diagnosed adrenocortical carcinoma. This is shown here. This is in green, the preoperative urine, again projected on red, confirmed carcinoma cases, steroid metabolomes, and blue, confirmed adenoma cases. These urines have been collected by the same patient when she was diagnosed with isolated liver metastasis that was then treated with radiofrequency ablation. And all these urines were collected ever since after that. So it's quite powerful also for recurrence detection. And to bring this into clinical practice, obviously GCMS is very low throughput. We had to transfer this to high throughput, and that was done by Ange Taylor in the lab, who developed an LCMS method that could perform multi-steroid profile with all the 9 relevant steroids in 10 minutes. And you see that GCMS on the left side and LCMS looks very comparable, and that was also the case when we looked at the GMLVQ analysis, completely similar performance of low throughput and high throughput mass spectrometry methods. So therefore, we could then undergo the next step on the biomarker development pathway for diagnostic tests, which is clinical validation, prospective clinical validation. And for this, I collaborated with my colleague John Deeks, who is a fantastic diagnostic test statistician. And he said to me, great news, after calculating things, you only need 2,000 patients, 2,000 consecutive patients with newly diagnosed adrenal tumors, and a 5% ACC rate, and then you can answer how good your test is. So, and obviously I told him that the largest study ever undertaken in adrenal tumors was an Italian study that retrospectively collected from 20 centers, 1,000 patients over 15 years. And obviously we wanted to have results before retirement. But obviously, I took up the challenge, and what we did, we designed the evaluation of urine steroid metabolomics in the differential diagnosis of adrenocortical tumor study, the URIN-ACT study. And URIN-ACT was possible, the UK was the lead center, but it was possible because of worldwide involvement, in particular pan-European involvement of multiple adrenal tumor specialist centers that recruited in a standardized fashion. And we were uniquely able to recruit more than 2,000 patients in 5.5 years that were all newly diagnosed adrenal masses. And it is important to say here, we excluded patients who had an adrenal mass detected upon diagnosis, staging, or screening of a known extraadrenal primary cancer. Yeah, so that was an exclusion criteria. And so this is a cohort, 4.9% adrenocortical carcinoma, and John Deeks was gracious and said, that's fine, that's almost 5%, and that's good to hear from a statistician. And because we collected uniquely so many and prospective patients, we also had small numbers of other malignant tumors and other benign tumors. So you see, if you use size, then you see that most of the benign tumors are under 5 centimeters and most of the malignant tumors are over 5 centimeters. But you need to appreciate the y-axis here. This is hundreds, and this goes up to 15. Yeah, and that means if you use size, 4 centimeter is a sensitive cutoff, but has a specificity of only 80%. Yeah, if you go to 2 centimeters, you have like only 30% specificity. And if you go higher, then you lose sensitivity, which is obviously not recommendable. So the second criteria that's commonly used is tumor density or tumor attenuation measured in Hounsfield unit or non-contrast CT. And if you apply the conventional cutoff of 10% that was previously always used, then 30% of the patients with benign tumors actually have imaging suspicious of carcinoma. Yeah, that means that a huge number of patients would then undergo surgery without a real necessity. Yeah, and we established in this study, in this prospective study, that a cutoff of 20 Hounsfield units is much more appropriate, as it maintains 99% sensitivity, but increases the very poor specificity of 64% at least to 80%. And in our study, that was obviously not interventional, but observational. This meant that the false positive number decreased from 423 to 200 patients. So in the, obviously all centers treated their patient as they saw fit, and 568 of the 2,100 patients underwent adrenalectomy. And according to the criteria of the histopathology, we knew that 38% of them did not require surgery. Yeah, so that's obviously huge health economics cost, and not to say risk for the patients. So we then went on to the urine analysis, which was obviously a group effort to undertake steroid mass spectrometry, even if it's high throughput, in more than 2,000 urine samples in one go. This was then analyzed with a machine learning algorithm, and then the scores were allocated low, moderate, or high risk according to a modified Delphi consensus with 21 clinicians. And we counted high risk as indicative of adrenocortical carcinoma, so a patient that could go immediately to surgery. And these are the results of the single tests. If you apply Zeiss or Hounsfield units, you see you get a lot of false positives here that would be operated without reason. You also get false positives with urine steroid metabolomics, but much fewer. If you combine these 3 tests together, then you see a progressive decline in false positives in the combination with urine steroid metabolomics. And if you combine all three, Zeiss, Hounsfield units, and urine steroid metabolomics, then you get a very small number of false positives, but maintain almost the same number of true positives. Yeah, so a new triple test for adrenocortical carcinoma, and we published this 2 years ago in The Lancet, and it was accompanied by an editorial. And obviously, we are now on our way to develop this for implementation in routine clinical practice. And this is just to illustrate the two lead fellows involved in this, Ange Taylor in the mass spec lab and Irina Bankos on the clinical side, who spent a 2-year fellowship with me and now is an associate professor at the Mayo Clinic. So this took a long time, proof of principle study, urine act recruitment, urine act analysis, and lots of children were born in the time, yeah, and both of them are now associate professors, so it was also productive by maintaining women in science. And obviously the most important slides, all the people who have contributed to this work, both the adrenal tumor work and the PCOS study. Many thanks.